So my name's Cora, and this is, as it says, Ask Me Anything, and I mean that quite literally. The purpose of this session is an opportunity to ask me anything. First, I just want to comment on something that Dr. Fuller had said, which I think is really poignant for me as I go to these different meetings, is that both of your groups are rare disease groups, and the fact that you've come together in a meaningful way is really powerful. So I've met a lot of Med13L families previously, but am meeting more CTNNB1s as part of this meeting, which is a wonderful thing. And by virtue of the researchers who are here and myself, we have probably now met more families with Med13L and CTNNB1 than any clinician will ever meet in their entire career. And that is an honor to actually have that experience. So it's my absolute honor to be here, more so than it is, and a privilege to actually speak to you and a privilege to meet your kids and do testing with them. And that's really huge. So thank you so much for the support from the family groups to bringing all the researchers here. And if they didn't say it out loud, I hope you know that in my conversations with them and from interacting with them, we feel it, that, you know, you bringing us here really does mean a lot, and we enjoy meeting your families and really getting to know you on a level that goes beyond just reading about what CTNNB1 or Med13L is. And it's a great privilege, and thank you for having us. So ask me anything probably sounds like a bold statement. So I've done this talk a few times for a few different family groups. And really, it's just about the idea that you guys have probably heard a million talks about behavior and sleep problems and feeding problems and things like, you know, you've heard it all. You have your behavior specialists in the school system who are, you know, working hard and using principles, and I am not here to regurgitate that information back to you for an additional time. What I want to do is facilitate a conversation where we can brainstorm ideas about complex situations that a lot of you are experiencing. Now, I have some ideas about some shared issues between the two groups and a lot of the things that bring you guys together. But if anyone is brave enough, does anyone have a question or a thought to start out, or something specific that might be going on with your child or your individual with Med13L or CTNNB1 that you think it might be helpful to chat through? And we'll go from there. And I'm going to need cowbell because at some point, yeah, tell me when to stop. Yep. Oh, we got one. Thank you.
Thank you. Hello. I'm Earl Weber. That's my wife, Heather. We have Elijah Weber. He's the 14-year-old boy in the wheelchair who's probably hit many of you, or pulled your hair, or yanked your lanyard off, or thrown food at you. And I apologize for that. He gets that entirely from his mother. So the question I have is the idea of psychology or psychiatry for these behavioral things as opposed to just being our general practitioner experimenting with different pharmaceutical products. But you know, that's something until we came to this conference that we hadn't even talked about or been talked to with about.
That's a great question. I'll start by giving you my thoughts, and then if other people want to chime in about what's been helpful or not helpful, I welcome that. So the first thought is that if you haven't engaged with a neurodevelopmental pediatrician, that would be my first recommendation. So there are two different kinds of developmental pediatricians. There's neurodevelopmental pediatricians and developmental behavioral pediatricians. They both are excellent in working with kids who have developmental disabilities. The reason I mention neurodevelopmental pediatrician is because they also have some expertise in neurology, which I think is quite relevant to both the Med13L and the CTNNB1 groups, especially given some of the motor concerns that you also see. But they also are able to prescribe medications as well. Sometimes individuals in if you're thinking about psychologists don't prescribe medications typically. Psychiatry would. Not all psychiatrists have necessarily the training or have the expertise to prescribe medications for individuals who have more profound impairment. And so you might find if you approach psychiatry that they'll say, we won't take your child because they don't feel comfortable prescribing when individuals have more cognitive impairment. But neurodevelopmental pediatricians or developmental behavioral pediatrics might strike a better balance between having the expertise and the comfort with prescribing some medications, if that's where you think you might be headed, to helping with some of that behavior and just going a step beyond. Now, they can be hard to find, and there are longer wait lists, but sometimes they could be worth the wait in order to get that more complex medication management. So if you talk to your pediatrician, or I'm happy to talk to anybody later and let you know where the heavy hitter centers are, where we know we have those. So around here, you certainly have, you have Dr. Chung here. She's not a developmental pediatrician, but certainly has areas of expertise, but there are developmental pediatricians in this area. Dr. Sid is another good one if you haven't interacted with him, but neurology is another place to also look at for some of those options for individuals who are willing to entertain additional options. Does anybody have similar thoughts on that or anything else to chime in on?
I have a similar thought, but we do have a great neurodevelopmental pediatrician. So her name's Dr. Awladala Bacon in Children's National in DC. She's fabulous. So we have an 11-year-old who has CTNNB1. His name is Win. And so we've really found a lot of success with her. She's hard to get on the waiting list for, but once you are and you email her, she's very quick to respond, very quick to address issues. So highly recommend.
Yeah, I think that it's often that initial wait that's hard to get through. It's like a long wait to get in, but usually once you get in, like you're in. So then, and then you really have a community or like a individual who, even if they may not be an expert specifically in CTNNB1 or Med13L, they have broad expertise in developmental disabilities and often rare genetic conditions too.
I'm Maggie. I have a 2.5-year-old with CTN. I'm just going to open the whole can of worms, if that's okay. Oh, God. Okay, so sleep issues, I know is a lot with a lot of us. Falling asleep, staying asleep. Maybe, we don't know if it's anxiety or something else, like, yeah. And then hitting, kicking, biting, pulling hair, the whole shebang. Where, like, what you were talking about before is, I think I don't even know where to start with this, but we're just kind of clueless about who would help with what, like with all the different behavioral issues.
Yeah, I think you're touching on a really important issue too, which kind of builds off the next question is, when do you decide to escalate? When do you decide to make that choice? Because nobody wants to go down that, right? As parents, we don't want to say, my child needs medication, right? I've never worked with a single family ever where they have said, I want to medicate my child and I just can't handle this, right? They want to exhaust every other option first. And you're getting at a point, it's like, okay, well, what options do we exhaust? So you're talking about two different things a little bit. So one is sleep and then the other is behavior. So let's talk about sleep. So sleep issues, yeah, that's about right. And then those of you who just didn't raise your hand because you didn't want to. So, I try to think about some of these things like, okay, what's the minimal intervention we can do? So the first thing is what people who are in the field will kind of refer to you as sleep hygiene, which just means, are you doing a bedtime schedule? Are you doing nap time? I'm pretty sure that all of you have exhausted that option, right? So you're doing everything that you should be doing with sleep hygiene. That doesn't mean that you should retire it just because you're going to try new things. You should try to keep that routine on schedule. But what do you try next? So the next thing is, okay, what could be available over the counter? Melatonin. That's probably the next thing that everybody said to you. Should you try melatonin? And so for those of you who haven't gone there yet, sometimes we were worried, okay, like, well, we'll just try a little teeny tiny dose. Anything under 1.5 milligrams, you're not even trying. So if you have tried 1.5 milligrams or under, it is not a therapeutic dose, right? You need to try at least 1.5 milligrams in order for it to even be feasible that it worked. If you're trying under that, you're just giving your child a treat at nighttime. Like, you're just giving them a gummy for the sake of giving them a gummy. So 1.5 milligrams or higher. Now, you can go higher, up to 5, up to 10, depending on the age of your child and the size of your child. But if they don't fall asleep within a half an hour of you giving them the melatonin, it is not working. So if you are giving them 10 milligrams of melatonin and they don't fall asleep relatively rapidly, again, you're just giving them an extra piece of candy at bedtime. It is not working. So then is where you think about, do you want to try medication options or do you need to try other things? I think about medication, as we think about sleep, as getting the ball in your court, right? So if your child is running laps around the bed and they're not even seeming to be tiring, then the medication might get the ball in your court. So then all the other things that you've been working on, the behavioral interventions, they might start to work if you get the ball in your court. Yep.
So the only thing that we have been prescribed so far is gabapentin, but it does absolutely nothing for her.
Yeah, so well, that's,
She's still running, she literally runs around her cubby bed, just not sleeping at all.
well, and I think that's the thing that, is the thread between this question and last question, is that if it doesn't work, don't take it, right? Like, if you were taking a medication for yourself and you don't see that it's working, then you should either try something different or stop it. So I'm surprised to hear that gabapentin would be the first thing. The most common medication that most individuals will go to after trying melatonin and trying all the behavioral strategies is actually clonidine, which is used off-label. So clonidine is a blood pressure medication. The side effect is that it makes you sleepy. And so it's often used off-label in that case. Now, to the earlier point, why you should see a neurodevelopmental pediatrician is that developmental pediatricians might be more inclined or more comfortable using drugs off-label. So,
Her neurologist that prescribed it to her.
okay. Yeah, so
That was the only thing she started.
okay, yeah, so I would start, I would go back. So again, I would say if it's not working, don't use it and go back and talk more. Yep, we have a comment.
I would just add for you, I had the same situation. We used melatonin and it made her wired. We went to gabapentin over a 6-week period, then she calmed down. It takes, oh, okay. So we found gabapentin worked really well.
4 times already on like day 4.
Every child's different.
So I have a question. My daughter, she has Med13L, and she's 3.5. And we also have the issue of the biting, the pinching, she's nonverbal, so we definitely think the frustration is coming out in that way. She's not diagnosed with autism yet. We're on the waiting list to get in. However, we were wondering about ABA therapy and if anybody has had any success with that.
It's a good question. The first, I'm going to get to you in 1 second. So the first thing I wanted to talk about actually is that for all these kids, from my interactions with them, is that communication is huge, right? So a lot of them have trouble communicating, and even if they can communicate a little bit, they might still have trouble having people understand them. So I met a bunch of kids yesterday where if I didn't have context of what they were trying to say to me, I probably wouldn't have understood at all, but they were trying to communicate with me. And I think that's the important thing to remember with behavior, is that if I was standing up here right now and you couldn't understand what I was saying, most of you would probably leave and I would probably be devastated, because I would like for people to listen to what I have to say. And I think that a lot of times that's what's going on with our kids. And I think it's important to remember that behavior is communication, especially when verbal communication is hard. So the point I always want to hammer, your kids are not bad. they're trying to tell you something. And that by virtue of engaging in some of these behaviors that we as a society might label as bad, it doesn't make what they want bad. So wanting your attention is not bad. That's not wrong. It's just how they go about it is not the way that we would like them to go about it. So in terms of ABA therapy, the first thing actually that your comment made me think of was actually that we would need to figure out how to best help your child communicate. So if you have a child who is not communicating, or even or communicating a little but not doing it very effectively, or not in a way that is clear, the first thing I would think about is a speech therapy evaluation specifically focused on what we call AAC devices, or augmentative and alternative communication. Based on what we know about Med13L and CTNNB1, there are really high rates of what we call apraxia of speech. So even when they become verbal, it gets really difficult to understand their speech. So sometimes we might have individuals who are really trying so hard to talk, but we don't understand them. And that is just as frustrating as not talking. And so we have some individuals in this community who are what in the professional world we would call multimodal communicators. So they use both verbal speech when they can, and they also use a device. Given what we know about these groups, I would be very early. If you know that your child has CTNNB1 or Med13L, I would say even before you get to the point of them making vocalizations, or you'll hear sometimes people say, well, wait till they're 4, see what happens. Don't wait. Don't wait in this population. Go ahead and give them a way to communicate, even if you think you want to wait. The research has shown that those devices, actually, if your child is going to be a verbal communicator, will encourage verbal communication. It will not hinder it. So I think sometimes that's the hesitation, like, I don't want to give them an iPad because then they'll just use the iPad. The research shows that actually the opposite is probably true, that giving the child an iPad or some other way to communicate, might be pictures, that is a effective way to help bring verbal speech about. So the first thing I would say is, let's find a way for your child to communicate so that we can eliminate the pinching and the biting, because right now they're not bad, they just don't have another strategy. And your ABA therapy, it's complicated insofar as it varies by country and by state and by your insurance. But ABA therapy is a really effective strategy, not just for autism or not. It's a really effective strategy for any child who has any kind of disability. If you look at the way that we treat childhood anxiety, childhood intellectual disability, childhood behavior conditions, they're all based in ABA. So I wouldn't hesitate going ahead and getting ABA if it's something that were to be available to you.
No time for one more question.
Oh, only one?
I want to follow up on that one.
Oh, okay, quick follow-up.
I just wanted to say, sorry.
Yep.
A lot of you know me because I never shut up about this, but I'm a pediatric speech therapist. I'm so happy you said everything in the exact way that you said it. And if anybody needs help with AAC, if you're not familiar or anything, I did just do the podcast also, but feel free to find me on Facebook and message me. My name's Megan Stanley. I can help because, yes, do it.
Thanks, Megan. Okay, one more. Okay, we'll go in the back. And I will be around today and tonight, so. Oh, you have a mic already.
I have a mic. Should I jump on the stage too?
Yes.
That'd be fun. Any tips or ideas on how to handle inappropriate touching with the world? We're touching everyone's everything all the time.
Yep. All right. So for those of you who don't know me, know that I made a friend here, Med13L friend, a couple years ago. Who still remembers me. And there are other, you guys are not alone in the rare disease community, that there are, that having that difficulty understanding appropriate social contact is really hard. And there are things that are real cute when you're 4 that are not cute when you're 14. So for those of you who have little kids, I would encourage you to start now and start trying to identify what those boundaries are. The mantra that I use is handshakes, not hugs. And the thing that is hard is you have to get everybody on board with that, including teachers. I mean, you think about preschool and kindergarten teachers, they like, kids who love them and want to sit on their lap. But again, it's cute at 4. It is not cute at 14. The context changes. If there's anything that we know about a lot of our kids is that they have trouble understanding context, that certain things are okay in this environment and with this person, but not okay with this person. So trying to start to set those boundaries as early as possible. So for those of you who have young kids, go ahead and start with handshakes, not hugs. And so if I interact with any of your kids, I will give them a handshake, not a hug, because in 10 years, when I see them again, or a fist bump, like that's okay. But we don't want to encourage the idea that, because at the end of the day, I may have met your kid, but functionally, I'm a stranger, and they should not be hugging me necessarily. And trying to understand who fits into what category, who is it okay to do this with versus who is it not okay. And you can add in subtleties to that when they get older and when they have more understanding. But when they're younger and they don't understand the difference between a stranger and a person that they know, you might have to set a firm boundary. Like people who live with us or people who are our family, we can hug. Everybody else we give handshakes to or fist bumps to. But if you can build in subtlety as they get older, as they mature, but sometimes at the younger age, or if they don't understand, you might have to set a firm boundary, at least for the time being.